Hello everyone, I am Dr. Sandeep Sharma. We are going to discuss FMGE January 2023 recall, the pediatric questions. Some of these questions are overlapping. Some of the questions do not have the complete options yet recalled. But what is more important is what were the areas asked, what you are supposed to remember, what are the takeaways, and what are the related points from the exam which has been held. So whether you are a future aspirant or you have just given the exam, you will be benefited from it. And I'll try to keep it short and not go into unnecessary details unless it is needed. And please also remember that if the recall changes, if the language of question changes, the options change, the answer is also liable to change. So it is all dependent upon the recall. So let us begin with question number 1. So question number 1 said a 5-year-old boy presented with, so it's a boy and it's a 5-year-old boy. He presented with periorbital and pedal edema with ascites. So the child is having a generalized body swelling edematous condition. On electron microscopy, effacement of foot process of podocytes was seen and is being treated with corticosteroids. What is the likely diagnosis? So this is a renal cause producing significant edema in the patient. So likely the child is having nephrotic syndrome. And which variety of nephrotic syndrome is common in children and has electron microscopic hallmark of foot effacement of foot process? Yes, the correct answer is minimal change disease, right? So it was an easy question. It was an indirect repeat question already asked in the past in FMGE exam. So have a look at these two images which are showing you the structure of a glomerulus. So if you cut section, you do microscopy, you will find that this is the lumen of a glomerular capillary. So you have blood here, then you have the endothelial cells lining which is there, then we have the glomerular basement membrane, and this is the podocyte layer of the foot process of cells. So this is the podocyte layer. This is the podocyte layer. Podocyte layer is called as podocyte layer because it has foot processes. You can see here that there are foot processes which are present. In case of patient with, this is a normal patient, and here you can see that in minimal change disease, there is loss, effacement, or clumping of the foot processes. So compared to this image, you can see that the foot processes, there has been complete effacement. It is a T cell mediated process which is common in children, but it shows a very good response to corticosteroids. So it shows a very good response to corticosteroids, right? So this is the complete glomerular capillary loop, what we mean by effacement of foot process of podocyte. Now, what is important for your future exams? Whenever you have a question telling you that there is a child presenting to you with edema, and the edema is suspected of renal origin, then there will be two possibilities. Either the child is having nephrotic syndrome or the child is having acute nephritic syndrome. This flowchart which I am making, it is very, very useful for your future exams, especially FMG exam. In case of nephrotic syndrome, the hallmark of these patients will be massive proteinuria, also called as nephrotic range proteinuria, and these children will have raised serum cholesterol as well. Although it is not a hallmark finding, but often we find that serum cholesterol is also elevated. Acute nephritic syndrome will have mild to moderate, also called as subnephrotic proteinuria. So proteinuria is there, but it is less. And these patients, acute nephritic syndrome, always have hematuria also and hypertension also. Oliguria may or may not be present. If it is nephrotic syndrome, there can be two possibilities. In case the child, 80% cases are found to have primary nephrotic syndrome, also called as minimal change disease. Minimal change disease. These are the patients who will be boys. It is more common in boys compared to girls. And the most common age group will be 2 to 6 years. How will you identify? It will be more common. They will more commonly have proteinuria, massive proteinuria, but there will be no hematuria in these patients. So no hematuria and no hypertension will be present at presentation in these patients. On light microscopy, you will find that there will be a normal finding, no abnormality will be found. So normal finding will be seen. That is why the name is minimal change disease. Minimal ka matlab koi change nahi hai. So minimal change disease. On electron microscopy, you will find effacement of foot process of podocytes, right? And when what is the treatment in these patients? They show a good response to corticosteroids. So good response to steroids will be seen in these patients. About 20% patients will be having the so-called secondary nephrotic syndrome, also called as nephrotic syndrome with significant glomerular lesions. These are the patients who will be aged less than 1 year or above 10 years. This is equally common in males and females, and this is the variety of nephrotic syndrome which sometimes resembles nephritic. Nephritic, we have already said, they will have hematuria, hypertension, but the proteinuria will be less. Here, there is massive proteinuria along with hematuria and hypertension. And the response to steroid is variable. So, the question which has been asked, this is the case which has been discussed with you, and that is the likely diagnosis. In future exam, if they make a difficult question, they can ask you about this. Sometimes if they say proteinuria is less, but hematuria and hypertension is there along with some edema, you will think of acute nephritic syndrome. In acute nephritic syndrome, remember that it is often precipitated by some infection. The most common cause of acute nephritic syndrome is post-streptococcal glomerulonephritis. How will post-streptococcal nephritis be asked in the question? Examiner will say there is a history of sore throat along with fever, or there will be a skin infection, streptococcal skin infection, followed by 1 to 3 weeks later, there will be onset of acute nephritic syndrome. It is a self-limited illness, but supportive therapy needs to be given and management needs to be done in these patients. So, post-streptococcal nephritis has been asked in the past papers. Minimal change disease was asked this year. It has also been asked in the past papers. So, this flowchart covers a lot of future approach questions for FMGE exam also. Let us move to question number 2. A young child with tumor of the eye showing intraorbital calcification and histology suggesting small round blue cells. What is the gene mutated producing this condition? So, tumor of the eye in a child. Second clue, intraorbital calcification. According to all the standard books, about 90 to 95% cases of retinoblastoma have evidence of intraorbital calcification. When you do biopsy, although excisional biopsy is usually indicated after enucleation we do. When you do, you will find small round blue cell, and sometimes rosettes formation can also be seen. What is the gene mutated? The diagnosis is retinoblastoma, and the gene involved in these patients is RB1 gene. So, answer is RB1 gene. Now, what are the things about retinoblastoma for future exams that you should remember? So, this video, I am trying to make it a quick review video, but I am also giving points so that you can revise this video before your next exam, next future FMG exam, which you will be sitting for. So, regarding retinoblastoma, remember the key points. It is the most common primary intraocular malignancy in childhood, right? Second thing about retinoblastoma, which has been asked in the exam, that is most common gene involved is RB1 gene. This gene involves a pathological concept called as, it shows Knudson's two-hit hypothesis. So, two types of hit or two types of mutations in the RB1 gene is responsible for producing this condition. These patients will have isolated unilateral white eye reflex. You can see in this child, can you see that there is a white eye reflex also called as leukocoria. Leukocoria, that is white pupillary reflex. White pupillary reflex usually unilaterally is seen in these patients, although it can be seen in other conditions also, but this is one of the feature. With or without, it may be associated with proptosis. Usually proptosis is a late sign. Some variants it may not be seen, but leukocoria, proptosis and RB1 gene involvement, retinoblastoma is the therapy. I am not going into the details. So, these are the points which have been asked in the past papers. You can add to your notes. Moving further, there was a child with fever, cough, rhinorrhea and conjunctivitis, developed a maculopapular rash on the body starting from the face. There was a cute kid photo given and the child was having rash. Now, whether it was a similar image or not, that we have no idea. But this is a child with measles kind of rash. You can see that there is watering from the eyes and stuffiness of the nose also, which is present in the child. What is the likely diagnosis? Obviously, the answer is measles. So, even if the other options are not recalled, you can easily make out that this is measles. So, regarding measles, what are the points that you should know? How the case will be asked in the exam? The question will say day 1, the child is having fever. Day 1 means when the illness starts. There will be fever with 3 C's. So fever with 3 C, cough, coryza, that is running and stuffy nose, conjunctivitis, inflammation and watering from the eyes. Along with second or third day of onset of fever, you will have enantheme. Enantheme. Exantheme क्या होता है? Rash. Any rash is also called as exantheme. Ex का मतलब बाहर. So exantheme is always a skin rash. Remember this, a useful concept. कभी कभी फंस जाते हैं लोग. And then enantheme. Enantheme refers to a mucosal lesion. So that you do not get stuck up, I am just writing in short. Sometimes FMGE and Neet PG examiners are fond of writing these lines. That is why I have incorporated here. So day 2 or day 3 pe, they will have mucosal lesion or enantheme. What kind of mucosal lesion? Coplic spot. Where do the coplic spot appear? Past MCQ point, opposite lower second molar tooth. Day 4, there will be a maculopapular rash. Rash first appears on face, then goes to trunk, then goes to limbs, and it is always a non-itchy rash. Treatment is supportive. Most of these children improve. However, the most common complication that you can find in these children is acute otitis media. And acute otitis media itself can cause hearing abnormalities, conductive deafness, sometimes discharge from the ear. Rarely can also be seen. Usually, it is a dry ear, dry inflammation, acute otitis media, which responds to, because it is a complication, so it responds to conservative therapy in most cases. So, this is the patient who's having measles, right? And this is the photograph of a child face you have already seen. On the trunk, the rash will appear like this, and these are the typical coplic spots. You can see coplic spots appear opposite lower second molar, mucosa में होते हैं, and they are called as rice grain like. Rice grain with surrounding erythema. That is how coplic spots are seen in these patients. Right? Let's move further. Question number 4. Easy one. Absolutely easy. Identify the enzyme deficient in Warg disease. It is a type of glycogen storage disease, GSD type 1, and the enzyme deficient here is glucose 6-phosphatase. Glucose 6-phosphatase is involved in the conversion of glucose 6-phosphate into glucose and removal of the phosphate residue. This enzyme is present in this here. If it is absent, then it leads to accumulation and back pressure changes, resulting in accumulation of glycogen deposits in the liver. There is hepatomegaly in the patient. Also, this glucose 6-phosphate can be diverted towards the other cellular pathways, producing other complications ranging from increased uric acid production to hypoglycemic episodes, etc. This is what you call as von Wieck disease. Sometimes they can repeat the question. It is also called as glycogen storage disease type 1. And what is the enzyme deficient? Glucose 6-phosphatase. Easy one. Question number 5. Look at the pedigree chart and tell the mode of inheritance. Now, pedigree charts are not very frequently asked in the FMGE exam, but for future exams, now you will have to go through them. Exact pedigree chart was not available. Now, in a pedigree chart, you know that a square represents a male and a circle represents a female. If it is a black and white pedigree chart, the darkened box will tell you the disease. On the other hand, if it is a colored chart, they will give you a color coding. So, this is a affected male, this is affected female, this is wild type male. Wild male means a normal male and wild female means a non-diseased female, right? So, these are the generations which have been shown. So, first generation, this diseased male married this lady. So, they had multiple children. So, they had this male who was affected, one male who was unaffected, two females which were affected, and one female which was unaffected, right? These two did not marry. Third generation also, there was disease happening. See that this male is transmitting the disease to female here, right? This female is transmitting the disease to both male and female. However, the person who is not affected, who is not carrying the disease, the gene, is not transmitting to any of their offspring. So, what are the takeaways from this? All generations are affected. What are the takeaways here? All generations are affected. That is the first takeaway from this photograph. Secondly, there is no gender predilection. Males are also getting affected, females are also getting affected, and there is no skipped generations. Skipped generations are usually seen in autosomal recessive conditions. gender predilection will be related to X-linked condition. So X-linked is also ruled out. So all generations affected, and approximately 50% of their children. See here, obviously they had 5 children, so you cannot say that 50% was affected or not. But if you see further, you will find that here in the third generation, from this 50% of offsprings are affected. Here also 50% of offsprings are affected. So about 50% of offsprings are affected in each generation. So this is autosomal dominant condition, right? In case it is autosomal recessive, there will be skipped generations, and normal parents, phenotypically normal parents, can have diseased offsprings. That will be autosomal recessive. If there is a gender predilection, then it will be a X-linked dominant or X-linked recessive. Remember that X-linked recessive will be transmitted by mother, will be transmitted to all the sons, and the maternal uncles will also be affected, right? So more details, obviously, you will have to go through the videos to understand them. So question number 5, it was a tough from FMG point of view. Autosomal dominant is the answer. Question number 6, easy one. Duchenne's muscular dystrophy involves which gene mutation? It involves dystrophin gene mutation. Also a past paper which has been asked on this. It is a X-linked recessive disorder. So X-linked recessive disorder means mothers are the carriers. Mothers can be carriers, and boys they manifest the disease. Boys manifest the disease. So DMD is significantly more common in male children. Question number 7, what is correct regarding the malnutrition image shown? What was the image shown? I don't know, but students said that there was a, if you have to identify a child with pot belly with edema in malnutrition, the answer is very simple. It's a often repeated question, that is kwashiorkor, and the kwashiorkor occurs, it is edematous malnutrition, maladaptive malnutrition. Calories may be suboptimal, but severe protein deficiency is the reason for kwashiorkor to develop. So what are the things about this that you should know? There are 2 varieties of severe acute malnutrition, also called as SAM. One is kwashiorkor, second is marasmus. Kwashiorkor is also called as fat sugar baby. Kwashiorkor is also called as maladaptive PEM, because they fail to adapt properly. Kwashiorkor is majorly related to severe protein deficiency, right? These children will have pot belly, so there will be a protuberant abdomen. They will have mental changes, so they will have irritability, and they will have apathy. Apathy is pathological disinterest, and they will also have edema. So these are the typical features that are mentioned in questions of kwashiorkor. Marasmus, look at this. This child is having alopecia, so baldness will be there. He is having severe wasting, and the child is having no edema. The child looks dangerous, but actually because there is less edema, the child has a better chance on recovery, on management. Both are severe conditions, both can be fatal, but which is more severe? Kwashiorkor is more severe. What is the reason for marasmus? Kwashiorkor due to severe protein deficiency, marasmus due to severe calories as well as severe protein deficiency. So both of them will be deficient in a patient of marasmus. Both of them have been asked in the past papers. Question number 8, an image with owl-eyed appearance. Now 2 types of owl-eyed appearance was asked in the FMG exam. So there was a lot of affinity for owl-eyed. One was related to CMV. Second was this malignancy-like condition where there were round blue cells also, and then the typical Reed-Sternberg cells were seen, and the answer is Reed-Sternberg cells seen in Hodgkin's lymphoma. Regarding Hodgkin's lymphoma, these days questions are being asked related to the subtypes of Hodgkin's of lymphoma. So this is a very useful table which I have added here. Please go through this table for future exams. So Hodgkin's lymphoma can have the typical forms, which are these 4, and then we have the atypical form that is different. All the typical forms, which is nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion, if you see, they all have Reed-Sternberg cells which are CD15 positive, CD30 positive, which is the typical one which has been shown here, owl-eyed appearance. On the other hand, lymphocyte predominant form is the atypical form. It will have CD15 minus, CD30 minus, so they are not present. CD20 is present in these patients. And if you look at the morphology, nodular sclerosis form will have frequent lacunar cell, occasional RS cells. RS is Reed-Sternberg cells. Mixed cellularity, frequent mononuclear cells and diagnostic RS cells will be there. Mononuclear cell with diagnostic RS cell and lymphocyte rich also. Lymphocyte depletion will have reticular variant of cells, whereas popcorn cells are a feature of lymphocytic predominance, right? So go through these things. These are more of a spotter kind of questions. If you have done a rapid revision close to the exam, you will be thorough with these. Then question number 9, which among the following is a contraindication to breastfeeding? Again, a repeat question. It is galactosemia in infancy. Galactosemia is a condition in which the child cannot produce enzymes involved in the conversion, in the utilization of galactose. Now, whenever the child takes milk, milk will have lactose in that. Lactose contains galactose, and because galactose cannot be metabolized, it forms toxic products leading to hepatomegaly, hypoglycemia, and even cataract can develop in the patient. And to avoid that, milk has to be avoided. So these children require specific management. They require specific dietary substitutes. And that is why absolute contraindication to breastfeeding is always galactosemia in infancy. HIV in mother is a relative contraindication, but according to the latest NACO 2021 guidelines, breastfeeding should be continued in HIV positive females in an Indian setting while you are giving prophylaxis to the baby, right? So galactosemia is the answer. Question number 10, breastfeeding should be started within how much time after birth? Now, there was no option of 30 minutes mentioned. Normally, conventionally, these days, the concept is you should start within 30 minutes of the birth. But if you look at the UNICEF guidelines and WHO guidelines, they still say 1 hour. And that is why in the options, they had the closest option was within 1 hour. And so that is your answer among the options given. Related to this, a lot of people say, sir, what if the option says within 30 minutes? Yes, within 30 minutes is what is being done these days. But the examiner stuck to what WHO says. UNICEF and WHO still say that exclusive breastfeeding for the first 6 months should be started within an hour of birth, right? But recently, yes, within 30 minutes, we are doing it. Question number 11, identify the condition shown in this image. What is this image? This is an easy one. This child is having genu valgum or knock knee. Now, there are two varieties, two forms you have already known. These are the two children. This is child who's having a genu valgum, that is knock knee, right? This is, their knees are close. How to remember? Gum. Gum makes the knees stick together. So, knees stick together. Knees stick together means there is due to gum. So, genu valgum is knees sticking together. This is genu varum. Genu varum. Varum, R-U-M. R-U-M is rum. Rum is a kind of alcohol. When you take alcohol, you are unstable and your legs, you will be walking with a increased gap between the knees. And that is why rum causes widened knees. This is a quick way to remember. This is not the pathogenesis. Please don't remember that as a pathogenesis. It's a way to remember. So, causes widened knees. So, genu varum. This is called as knock knee. This is called as bow legs, right? So, they are often manifestation. They can be physiological also. More commonly, if they ask you in young child, what is the common reason? The common reason is nutritional rickets in the patient, right? Rickets can have knock knee. They can have bow legs. They can have knock knee in one side and bow leg on the other side, producing the so-called wind-swept deformity in the knees as well. So, this is a combination of the two, which is rare, is called as wind-swept deformity. Wind-swept deformity of lower limbs is seen in rickets, and wind-swept deformity of the hands is a feature of rheumatoid arthritis seen in adults. So, I am not going into those details. Question number 12, there was a clinical case of sunflower cataract and Kesher-Fleischer rings in the cornea of eye, which occurs due to deposition of which mineral? Yes, it is due to excess copper deposition. The disease underlying is Wilson's disease. So, this is the Kesher-Fleischer ring. You can see there is copper golden brown deposition as a ring-like structure in the Descemet's membrane of cornea, and this is the so-called sunflower cataract. What are the things about Wilson disease that you should know? They have been asked in the exam. It is an autosomal recessive condition. So, it shows autosomal recessive inheritance. What is the gene involved? ATPase 7B gene. also sometimes written as ATP7B gene, right? So ATP7B gene codes for a copper transporter. Now, because this copper transport is defective, there is reduced excretion of copper from the liver into the bile and from there to outside of the body. And so these patients will have liver deposits getting increased, producing cirrhosis-like condition. They will have leakage of free copper into the bloodstream, causing hemolysis. They can have deposition into the brain, causing Parkinson-like features and psychotic changes. They can also have eye deposition. These are the eye manifestation, Kesher fissuring and sunflower cataract. So this is sunflower cataract. So chelation therapy will be indicated in Wilson's disease. Wilson's disease, hugely important. Even if you have cracked FMGE exam, for Neet PG also, for next exam also, it is a very, very important topic. So go through the topic in details. Question number 13, easy one-liner. Which of the following vitamin is deficient in xerophthalmia? Xerophthalmia arises due to vitamin A deficiency. I'm not going into details, you know it already. Question number 14, a question on dose of vitamin A in a 8-month-old baby. If they don't mention anything else, obviously, if the weight is mentioned, other things are mentioned, there can be variations of the question. But if they ask simply, the answer will be 1 lakh international unit. What is to remember? See, if you have to give mega dose of vitamin A in vitamin A deficiency state, less than 6 months of age, the dose is 50,000 international unit per dose. If it is 6 to 12 months, it will be 1 lakh international units. And above 12 months, the dose will be 2 lakh international units. The only exception will be if there is a child aged more than 1 year, but his weight is less than 8 kg, in these you will give half the age appropriate dose. Instead of 2 lakh, if agar aapne 2 lakh dena tha, now you will be giving 1 lakh in these patients, right? So please remember this. Question 15, NRP. NRP is Neonatal Resuscitation Protocol. There was a question asked, CPR is started when in a newborn. Now the exact recall is not yet, just a few hours back the exam has happened. So we don't have a recall and controversial recalls are coming. So what is to remember? So two types of recalls people were saying. If they ask when to start positive pressure ventilation, PPV, in a neonate, the answer will be if heart rate is less than 100 per minute. And if they ask when to start CPR or chest compressions in a newborn, the answer will be when the heart rate dips below 60 per minute. So please remember these two cutoffs. Details of the neonatal resuscitation protocol, obviously, I have discussed at multiple forums. I have also discussed in my quick revision program. I have also discussed in my detailed videos, right? So depending upon how the question was framed, you can have your correct answer. Question number 16, there was a clinical case of meningitis. Mentioned facts were weight loss, hilar lymphadenopathy in the lungs on imaging. CSF showed reduced glucose and lymphocytic predominance was seen in the CSF. What is the likely diagnosis? Obviously, the answer is tubercular meningitis. What are the points in favor? Weight loss, lung changes, the patient is having reduced glucose. Reduced glucose can be there in both pyogenic and tubercular. Lymphocytic predominance goes more in favor of tubercular meningitis, right? So what are the things about meningitis that you should know? When to suspect? Let us do a rapid review here. Whenever there is a child who's having fever, headache, vomiting, photophobia, and neck stiffness, right? You look for meningeal signs. You will look for meningeal signs in the patient. What are the meningeal signs? There can be nuchal rigidity, also called as neck rigidity. There can be Kernig sign and there can be Brudzinski sign, right? If they are present, if any of them is present, you should suspect meningitis in the patient. Now, if there is meningitis, if there is no raised intracranial pressure, brain ka pressure raised nahi hai, if there is no raised intracranial pressure, perform lumbar puncture and check for CSF. So CSF analysis is the investigation of choice. So lumbar puncture for CSF analysis is the investigation of choice. If there is raised ICP, then lumbar puncture is contraindicated. तो क्या करेंगे इन पेशेंट्स में? You will do a contrast enhanced CT scan of brain should be done and consider antibiotics, right? Now, when you do CSF, if you find that the patient is having raised cells, majorly they are neutrophils. Raised cells is also called as pleocytosis. So, raised cell is also called as pleocytosis. So, pleocytosis is of neutrophil variety. The patient is having low glucose and the patient is having raised protein. In these patients, you should suspect a pyogenic, also called as bacterial meningitis. In case there are pleocytosis, increased cells, but they are lymphocytic, there is reduced glucose, there is significantly raised protein, then you should consider tubercular meningitis, especially if there is a extra CNS focus of in the lungs or there is a history of contact with tuberculosis or significant weight loss. Again, TB becomes a more important differential diagnosis. And in case there are raised cells, which are lymphocytes, normal glucose and slightly raised protein, you should think of aseptic or viral meningitis. And what is the therapy in pyogenic meningitis? Yes, the drug of choice in these patients is third generation cephalosporin, that is ceftriaxone or cefotaxime, which should be given for 10 to 14 days. If you specify, if there is a specific organism which is cultured, for example, Neisseria meningitis, you will give for 5 to 7 days. If it is Haemophilus influenza, the duration will become different. But pneumococcal and empirical therapy, 10 to 14 days will be the likely answer. So, this flow chart, I have summarized whatever you need to know in a quick revision form for your meningitis related questions. This exam, paper 1 was relatively easy, paper 1 was tougher. The clinical exams are becoming tougher, clinical subjects are becoming tougher, OBG, PSM, surgery were tougher, pediatrics was moderate to tougher side. But if you are thorough with the frequently asked topics, you will do well in the exam. So, as more recalls, more suggestions are welcome, and based upon the recalls, if any further recall is available, we can incorporate it later. I hope you all do well in the exam and best wishes for your future. Thank you very much.